So without further ado, today we have the privilege of having Dr. Dhruv Krishnan, who is joining us from University of Ottawa. And without further ado, please go ahead.
Thanks, Dr. Shao. Sorry for the technical delay, everybody. Good morning for those of you I haven't met. I'm Dhruv. I'm one of the visiting PGY5 cardiology residents from Ottawa, working in the Echo Lab this month. And so I guess with every echo I've read over the past couple of weeks, I find myself inevitably getting into a staring match with that nebulous purple box that resides in the new diastolic function guidelines. And so I think I kind of had been asking myself what the deal with left atrial strain was and thought it might be a good topic to chat about today. And sort of over the course of reading into this talk, realized that there are some interesting things with respect to diastology, but also maybe some other potential clinical applications as well that I'm hoping to share with you guys as well. So title for today is Stretching the Truth, What Left Atrial Strain Tells Us About the Heart. Objectives for the talk are to understand the biophysical principles that underlie left atrial strain imaging, describe techniques for measuring LA strain using speckle-tracking echo, discussing clinical applications of LA strain in various cardiac conditions, and recognizing limitations as well as some future directions for LA strain assessment. So I think before we delve any further into left atrial strain analysis, it's important that we have a good understanding of the heart chamber that we're discussing. So, as I'm sure all of you know, the left atrium is one of the four major chambers. It's the most posteriorly directed, just sort of anterior to the esophagus and the chest. Embryologically, it originates from the primitive left atrium and the sinus of the pulmonary veins that come together to form the left atrium. And there's obviously multiple components that can be talked about at length, but sort of the main macroscopically visualizable, or the ones that we can sometimes see on echo, would be the attachments to the pulmonary vein on the posterior aspect. In most people, two of each, left and right. The anterior atrial septum, where if there is a PFO valve, that's where it typically is located. The left atrial appendage, which is often on the opposite wall, sort of narrow finger-like projection. And then the vestibule, which is the thin structure inferiorly, which basically refers to the part where it connects with the mitral orifice and then subsequently the LV. There's obviously multiple other parts to the LA, of course, but maybe a little bit less relevant to its functioning from a sort of hemodynamic biomechanic perspective for the purposes of the strain talk. And just a couple of other important points to understand about the LA before we proceed to talk about its function. One being, so it does have a certain wall thickness of about 3.5 to 6.5 millimeters on studies based on some autopsies, and it does include a muscular layer which does contract in end diastole, and I think it's important for us to keep that in mind because we don't often think of it as being a muscular structure, but it does have that important function as well. And in addition, most of the left atrium is surrounded by the parietal pericardium. However, there is the oblique sinus, which is the sort of anatomical negative space that runs sort of along the posterior aspect where it's not entirely bound. And so this allows for it to freely pulsate and contract and expand, which is obviously also important when thinking about strain mechanics. So on to some basic left atrial physiology. And again, this is something that could be discussed in far greater detail, but for the interest of moving on to talking about some more echo and strain-related topics, I'll keep it relatively simple. And I think with respect to handling of the passage of blood through the left atrium, the role of the LA can basically be broken down into three separate phases. And I think the most helpful analogy is to basically think of it as a dam. So, the fundamental function of a dam is to be a reservoir for water, to guide its passage downstream through a conduit. And then in many dams is also the case is to pump blood forward into other structures or other chambers. And so similarly, when discussing the left atrial biomechanics, the left atrium's function is commonly divided into three phases as well. So you have the reservoir phase when the mitral valve is closed and the left atrium fills with blood while ventricular systole is taking place. Then you have the conduit phase where the mitral valve is opened, and now blood is allowed to flow freely, ideally from the pulmonary veins into the left ventricle during early diastole. And then lastly, we have the contractile phase, sometimes called the booster pump phase, when atrial contraction causes further filling of the left ventricle. And it's important to remember that this is not an insignificant contribution with respect to LV filling and ultimately cardiac output, with many studies sort of quoting around 15 to 30% of LV filling being responsible or thanks to atrial contraction. So, being familiar with the determinants of left atrial function is critical, I think, to understanding the potential clinical applicability of left atrial strain as well as its limitations. So I got this picture up here because I think it's important to acknowledge that many of these factors are sort of both chicken and egg factors. Not only is the left atrial strain susceptible to these variables, but also left atrial intrinsic structure and function will directly impact many of these things, such as blood inflow from the pulmonary veins or into the LV and through the mitral valve. Similarly, we know that electrical dysrhythmia, such as AFib, can not only cause alterations in LA biomechanics, but can also be a consequence of different left atrial loading factors. And so this isn't by any means an exhaustive list, but I think it's important to consider variables such as these with respect to the musculature and contractility, the electrical conduction, the entry and exit points, sort of the pressures that the chamber is subject to, and its inherent geometry that all play sort of a role in and are also influenced by left atrial biomechanics. So just shifting gears a little bit to talk about some of the basics behind strain. I know there was a talk last week that discussed some similar concepts, so I'll sort of instead focus a little bit on some definitions and actually maybe some more behind the origin and history around the technology of strain. So strain is actually a word that comes from the field of continuum mechanics and may be used to describe deformations of any structure, including the heart. So when it comes to cardiac imaging, the term strain is used to describe myocardial shortening and thickening, which are the fundamental features of myocardial function, longitudinally, circumferentially, and radially. And so myocardial strain imaging quantifies cardiac deformation. And in order to perform a strain analysis, I think whatever the technology being used, I think it's just important to understand that regardless of the technology, the underlying requirement is the ability to be able to track separate moving parts of the myocardium simultaneously over the cardiac cycle and seeing how they're moving individually and seeing how they move in relation to each other and the walls on which they are located. So strain analysis, at least for the myocardium, was first probably understood and explored kind of in the early to mid 1980s, with some of the first papers being published on canine subjects, a lot of them from Dr. Waldman here, such as this one from 1985. And so what they would do in order to track myocardial deformation and strain would be to actually implant multiple tiny radiopaque sort of chips into different parts of the beating animal left ventricular myocardium, and use basically simple X-rays to record particle movement over the course of the cardiac cycle. And they correlate that with invasive LV hemodynamic monitoring at the same time to sort of get a better understanding of the physiology. In live human subjects, myocardial strain, with the help of advanced cardiac imaging, first emerged sort of in the early 1990s with the use initially with a cardiac MRI. And again, for at this point and for the subsequent sort of even couple of decades, the focus remained entirely on the left ventricle. And so the first sort of technology came out was through using a series of radio frequency pulsations to form what was called tissue tagging, where basically the image would be labeled, certain parts of the myocardium would be labeled, and they track their movement over different planes. The drawbacks with early MRI were that these tags could sort of fade at end diastole when the heart wasn't moving very well. And so diastolic function was an issue for a long time with cardiac MRI with regards to myocardial strain. But as MRI became more developed and more sophisticated for particularly CMR, the method was replaced by what we use more commonly now called feature tracking, where standard images are required, such as the 4-chamber that you can see here. And the MRI is basically able to identify the endocardial border and then track this over different parts of the cardiac cycle and in different planes to create a more accurate strain map and a strain map more quickly. In a lot of studies, I think because it was first and because of how much time it has had to evolve and how much cross-validation has happened invasively, MRI is actually considered the gold standard for a lot of myocardial strain. But we'll sort of discuss how some of these methods compare to echo shortly. So then moving on to echo, we're sort of still in the early 1990s. LV strain actually first emerged and was done actually initially with tissue Doppler, 1D or sort of M mode echo. And so the benefit of that mode was that, it could be done even if the image quality wasn't that clear. As we know, we get pretty good quality images with M mode, and we can get those E prime velocities, even if we can't see the borders very well. So that was an advantage. But the downsides obviously were that it required multiple dedicated acquisitions. The software did not create a map like we have today, and so you'd have to do tissue Dopplers in multiple different locations. And as you know, tissue Doppler is dependent on the angle of inclination, and so the combination of these factors meant it was ultimately a pretty time-consuming process. Now, as I'm sure most of you know, also from the chat from last week, strain analysis and echocardiography today's era is almost exclusively done through technology that's called speckle-tracking. And it's important to remember speckles are not actually particles, but they're caused by interference patterns between cells of different ultrasound densities. And so they move together with the tissue for a limited period of time and distance, and so that's why they're used as features for tracking. Compared to tissue Doppler, obviously it is reliant on having somewhat better quality images, which can in some cases be a limitation. But the benefits are, for the most part, are thought to outweigh that in that you don't need as many dedicated images of the LV. Basically just a few standard apicals for most intents and purposes. So that's why it sort of largely replaced Doppler strain. And then just one more thing about speckle tracking and strain analysis for the LV, that we usually sort of refer to things in absolute numbers. But as you may recall, we're often dealing with negative numbers. And because of the mathematics behind the strain analysis and the fact that the distance between the tracked speckles is actually shortening when the cardiac chamber is contracted. So recognizing that tissue Doppler echo strain has sort of significant limitations, has fallen out of favor, we're left with kind of choosing between MRI, 2D speckle tracking, and also 3D speckle tracking, which is possible. And so how do these modalities stack up against each other? First off with MRI, the benefits are of a CMR analysis of strain are the high definition of the endocardial borders, the high signal to noise ratio, with relative technical feasibility, and the reproducibility. But where CMR loses points is the fact that its temporal resolution isn't as good as echo, which can be a problem, particularly for more tachycardic patients. In addition, spatial resolution in CMR is reasonable to the tune of a few millimeters, but isn't as good as 2D echo in some cases, and that margin of error may or may not prove relevant. And this isn't to mention, of course, significant interventor differences and obviously the logistical issues surrounding accessibility and cost of performing this kind of analysis routinely on a large number of patients. In contrast, a 2D speckle tracking echo strain analysis has a moderate but not quite as good signal to noise ratio as MRI, but it does definitely score points for its high temporal and spatial resolution, as well as feasibility and reproducibility, not to mention, in most cases, sort of cost and accessibility of the echo technology versus MRI technology. And interventor differences are also relatively smaller. Now, 3D STE, unfortunately, suffers from lower signal to noise ratio, temporal and spatial resolution, feasibility, reproducibility, and interventor differences. It's also relatively newer on the field. And so for all of these reasons, at the moment, it's not currently the preferred choice for most applications of strain. So now on more specifically to left atrial strain. When calculating myocardial strain, it's common to use what in the mathematics and physics world is known as this Lagrangian description that uses end diastolic length as the reference, hence why in LV, global longitudinal strain, we're dealing with negative numbers because the LV cavity is very small. Initially, actually, in myocardial strain, they used what's called an Eulerian description, where they used the deformed myocardium as the reference, and so they were dealing with positive numbers, but over time, the convention has just been to switch to predominantly the Lagrangian conventions. To recalling our understanding of left atrial biomechanics, there are these three phases of strain, which we use clinically. The first one being reservoir strain. Again, when the mitral valve is closed, the left atrium is filling. Typical normal values are about 30 to 40%. Then we have conduit strain, which is from the peak of the reservoir down to a plateau during early diastole before the atria is contracted, where the numbers are getting lower because the left atrium is starting to empty, 10 to 20%. And then there's contractile strain for the very end, the atrial kick, where the numbers usually drop to 10 to 20% in normal subjects. Now, of course, to perform this analysis, one must be synced with the cardiac cycle. And so, the ECG leads when performing this are incredibly important. So I just wanted to show this again from a sort of graphical point of view. So just ignore the scale on the y-axis because it's a little bit off, but this is just to help sort of visually depict the fact that you can see three phases and how strain increases during the reservoir phase as the atrium expands, and then sequentially sort of decreases over the conduit and the booster pump or the contractile phases. So our understanding of what a normal left atrial strain comes from the study by Singh et al. Published in 2021 in the AAC journal. They performed a strain analysis on almost 1,800 healthy subjects. And as you can see, there's quite a significant range to what a normal strain is. And further, there are quite significant differences when it comes to sex and age. And these details will actually be important when it comes to our ability to reliably use left atrial strain analysis in clinical practice, and we'll talk about how that is sometimes a limitation. So on to how actually to measure left atrial strain for the echocardiographers or anyone who's had to do strain before. This won't be that unfamiliar, but relatively similar to how you might do it for the LV. So you obtain your dedicated LA views, typically in the apical 4 and the apical 2s. You optimize your image of the LA, trying to enhance the border as well as possible while minimizing artifact with a narrow image sector and optimal frame rate. And make sure that your ECG, and this is probably particularly important for strain, not only that the leads are on, but you have the best lead possible to be able to view the P wave if they are in sinus rhythm and sort of map out the strain over the cardiac cycle. Capture about 3 to 5 beats that are relatively similar in heart rate, and then use your tracking software to basically produce your strain analysis. Again, looks fairly similar. So here's an example of sort of analysis that some of the machines in the software on the market will produce. You can see kind of the blue delineation of the left atrial borders, which in the apical 4 and the apical 2, that's acquired through the speckle tracking. And then you're given this graph here, as well as some of the more specific numbers to the right. The green dot here represents the peak of the strain curve during the reservoir phase, and then the red dots represent the peak strain at onset of atrial contraction, so just prior to the A wave. And this just shows in a bit more granular detail how these values are then explicitly calculated. So, you know, and it just highlights the importance of being able to, or using the ECG, using your Doppler signals, and then using the understanding of the curve as well as the peak strain values to be able to break things into reservoir strain, conjugate strain, and contractile strain. So we've seen that there's significant variability among patients, even who have even quote normal end quote left atrial strain. But what about the actual reproducibility of performing these measurements? So the good news is that the inter and intra-observer variability is usually less than 5% among skilled operators. Feasibility is close to 90%, but factors that can get in the way are, you know, not unfamiliar to a lot of what we deal with in echo and diastology, which are, you know, image quality, atrial fibrillation, or other rhythms, and you know, vendor differences can also have impacts in straining for the same patient. And ways to optimize these are some of the things we already do for any of our patients who are undergoing an echo assessment, which are trying to average things over multiple frames, breath holding, more beat averaging when it comes to atrial fibrillation. So on to some clinical applications. You know, LA strain and echo has been around for almost close to 2 decades now. It was with respect to the left atrium, but only recently is its uptake sort of starting to increase a little bit more. Its use has been studied and proposed in a wide array of fields. And I think the one people are most familiar with, or at least have most exposure with, is diastology. And as you can see, there are a number of other fields where this is being explored, but I think the ones that I want to focus on today were, you know, with respect to diastolic function assessment, as well as some sort of interesting findings and perhaps uses when it comes to MR prognostication and assessment, as well as post-electrocardioversion management and atrial fibrillation. So these are pulled, you know, directly from the diastolic dysfunction guidelines, which is basically just to illustrate that, you know, the underlying principle is that we know through invasive hemodynamics that there is some correlation between left atrial biomechanics and pressures and LV filling pressures, and the correlation isn't perfect, but the whole idea is to try and give us a non-invasive surrogate that can replicate what's going on with respect to LV relaxation, stiffness, and filling pressures as closely as possible. So I'm sure everybody has seen this at some point recently, but this is, you know, the central figure from the most recent diastolic function assessment guidelines from the AC from June of just this year. And as you can see, left atrial reservoir strain is one of the proposed mechanisms to quantify left atrial pressures and then subsequently categorize the severity of diastolic dysfunction. They use a cutoff of 18%, which is what is borne out in most of the literature. You know, as you'll recall, normal values across both sexes and most age groups is kind of roughly 30 to 40%. You know, and some studies have proposed different cutoffs, but at the end of the day, we're playing this game where we're trying to trade off some sensitivity for a false positive rate, and a cutoff of less than or equal to 18% is sort of the one that's been agreed upon as the best balance of the two. And this is probably one of the studies that helped influence these guidelines, and This slide, I think, provides a comparison of how left atrial reservoir strain compares to some of the other older, kind of more conventional or widely employed parameters that are currently used as part of diastolic function and LV filling pressure assessment. I don't know if you can see there, but comparison to, for example, the E over E prime, the LAVI, and the TR jet velocity. And this study actually also used a cutoff of 18% as significant. And this was published in 2022. They looked at 300 odd patients and compared their invasively measured LV filling pressures with multiple non-invasive assessment strategies, including left atrial strain. So just to orient everyone who might not be familiar with these diagrams, a model that would suggest a strong linear relationship between a variable and the LV filling pressures would ideally feature the points sort of closely clustered along the line and less scattered. And then this value here on the top right for each of these diagrams is the Pearson correlation coefficient that spans between -1 and 1 by definition. And so values that are between 0.6 and 0.1, or -0.6 and -1, or sorry, 0.6 and 1, or -0.6 and -1 are considered good with respect to correlation. So as you can see here, the left atrial reservoir strain map perhaps slightly edges out some of the more conventional parameters with regard to the Pearson coefficient, but just from the eyeball test, you can already see there's a whole lot of scatter, and the coefficient is not even within the good category by most conventions, so it's still far from an imperfect or from a perfect a variable or any sort of silver bullet. Here, this is our receiver operating characteristic curve where sensitivity is on the x-axis, on the y-axis, and then 1 minus specificity, which is basically the false positive rates on the x-axis. And in these graphs, essentially, the larger the area under the curve in the top left here, it would suggest that the model is better at discriminating between normal and abnormal LV filling pressures. And in this sort of ROC curve or ROC graph, values over 0.7 are traditionally considered acceptable. And then when you get into over 0.8, you're getting into the finally good or more than just acceptable category. And again, you can see that these models that incorporate left atrial reservoir strain perhaps inch out some of the more conventional ones, but even they don't really break into the good category by any means. This is also from the same study, and this is important because it reveals one of the more significant downsides or sort of limitations of left atrial reservoir strain in diastology, which is that although the model is pretty strong at predicting diastolic function in patients who have a normal or abnormal LVEF or already abnormal straining patterns by these big areas under the curve here, when you're dealing with patients who have normal LVEF or normal strain, they are significantly less helpful. And I think a lot of people find this disappointing because it means although there's some promise from what we've seen so far to the applicability of left atrial reservoir strain in diastolic function assessment, this doesn't get us that much closer to identifying those HFpEFers who have, on first glance, a structurally normally appearing myocardium, and doesn't get us much closer to understanding their physiology and their LV stiffness and relaxation patterns than the other conventional variables. And so these points here are actually directly from the diastolic function guidelines themselves from this year, which refer to some of the limitations or reasons to pause when it comes to left atrial reservoir strain in diastology. And a lot of them we already talked about, but essentially that the values are age dependent and there's a very broad range. This point here that we just talked about, that it's really dependent on LV systolic function and global longitudinal strain. And so when these are normal, the model becomes less helpful. Of course, it is very important to be able to track the heart rhythm when doing a strain analysis. And so and even RR gating in and of itself may be a somewhat inaccurate substitution for end-diastole, especially if there's any sort of other conduction abnormalities. In addition, when the left atrium itself is perhaps more structurally abnormal, or the atrial septal wall is particularly thin, or there's any other sort of significant deviations in geometry, the technology is less good at sort of creating a strain map. And then lastly, we're still not free from the challenges of assessing diastology in patients who have atrial fibrillation or significant mitral valve disease. And so this isn't sort of a cure-all for those issues either that we already deal with a lot of the conventional variables. So just moving on to a lesser known maybe potential future application of left atrial reservoir strain and echo assessment, which is the sort of assessment and prognostication of mitral regurgitation. First we'll look at the data for secondary MR from the study by Stassen et al. In 2022, which looked at 666 patients with at least grade 2 secondary MR. And as I'll show you on some graphs on the next slide, it's interesting that left atrial reservoir strain independently was associated with MR severity and eventual mortality, even when adjusted for LAVI and some of the other conventional markers that we use to assess mitral regurgitation and help direct timing of intervention. And there was evidence of incremental prognostic value over the use of SLAVI and global longitudinal strain alone. So just to highlight that again, you can see here in this particular study, they used a left atrial reservoir strain cutoff of just under 10%. And you can see that those that did have this decreased strain had significantly decreased survival over a matter of even just a couple of years. And then this graph on the right basically shows where the y-axis is the strength of the model at predicting mortality. And you can see compared to conventional variables, so here you have LVEF, global longitudinal strain, and LAVI, when left atrial reservoir strain is added to the mix, there is a significant improvement in the ability to sort of predict mortality in these patients. What about in primary MR? So the same group actually published a paper in the same year about patients with primary MR. So these were patients with severe primary MR who were already pending mitral valve repair. And they explored a lot of the same outcomes, mortality in and around the time of the procedure. And again, they found that there was an independently associated relationship with all-cause mortality, even adjusting for some of those conventional factors. Here, showing a similar graph, where they had about 600 patients, and there did seem to be some incremental prognostic value by adding this to a model that already included, some baseline demographic comorbid criteria, as well as some of the other metrics that we typically assess in patients with MR. So I think this opens up some exciting potential here, probably with some future research for the role of left atrial reservoir strain in prognosticating patients with MR, and maybe even helping guide timing or indications for intervention. I think questions that maybe we could answer with this technology with a little bit more data could be, should we be intervening on patients whose left atrial reservoir strain is starting to become abnormal, even if they don't, by other criteria, meet any indications for an intervention on their mitral valve? Should we be trying to intervene before the reservoir strain gets to a certain point that is bad enough that then signifies that they might do poorly after their mitral valve is repaired, because we know it's associated with worsening mortality? And so, obviously a lot more data will need to be gathered on sort of much larger, much broader cohorts before any of this has a chance to make it into any sort of guidelines. But I think it's a really important concept that might be worth keeping an eye on over the coming years. And lastly, I just wanted to talk about the potential role of left atrial reservoir strain in atrial fibrillation, and specifically about its ability to predict the chances of achieving success in restoring a sinus rhythm. So there was a meta-analysis done here in 2024 that was published in the Journal of Clinical Medicine that looked at this specific question and found that left atrial strain deterioration independently correlated with AF recurrence after electrical cardioversion. And it was also correlated with failure of the electrical cardioversion in the acute setting. And this was both in absolute terms, but also even when adjusting for left atrial volume. So I think you wonder, or it makes me wonder in the future, with this data, if it was borne out in future studies with more patients, and if strain analysis, left atrial strain analysis in patients with AF might play a role in how providers and patients might come to decide upon rate versus rhythm control strategies or sort of subsequent management of AF going forward. Similarly, we know that, patients post electrical cardioversion are at increased risk of cardioembolic events due to LA stunning and increased stasis and then subsequent clot formation and embolism. And there have been a few studies which have examined whether left atrial strain might help predict pericardioversion cardioembolism risk. And so this group here, Costa et al. In 2016, did a study to look for any relationship between left atrial reservoir strain and decreased tissue velocities in the left atrial appendage, which we understand from some other studies is associated with thrombus formation. And so they found that left atrial strain was an independent predictor of decreased left atrial appendage blood flow velocities. Again, not translating directly into cardioembolic events, but blood flow velocities, even when accounting for LAVI and even independent of the CHA2DS2-VASc score. And so if that's borne out in larger studies, that might also be very important information for patients and providers to take into account when deciding management strategies for AFib, or perhaps even going for LAA closure devices and sort of the whole gamut of associated potential therapies. This graph is basically from that study, which is that PPS is what they call percentage strain, and that there was a significant independent relationship between that and velocities in the left atrial appendage. And so, there's clearly some promising areas where left atrial strain might be playing a role in the near future, but a lot more research would need to be done. And I think a couple of other things that we might continue to see evolve along with this technology over the near future would be something that's occurring in a lot of cardiac imaging, which is AI integration for automated strain analysis. As 3D echo improves, we 3D speckle-tracking echo for volumetric strain, and whether that has any further utility or different information. More studies done sort of comparing head-to-head some of the different multimodality imaging and how they might provide different quality data with regard to strain or different information altogether. And of course, as we've talked about, ongoing trials to really sort of examine the role of strain in a number of different clinical contexts to see if there actually is a role in affecting patient management or prognosis. So just to conclude with a couple of points, left atrial strain's an emerging technology that seeks to provide new insights into atrial mechanics beyond traditional metrics. Left atrial strain assessment is based upon the understanding of the biomechanics of the LA as a reservoir, a conduit, and a contractile chamber. The application of left atrial strain in clinical practice has shown various degrees of promise and incremental benefit to our current understanding of these conditions. And lastly, of course, future research is needed to further validate the technology and explore other potential uses and compare it to other methods of strain assessment. So I've just got a couple of references here, and then I'm happy to open things up to questions.